Okay, continuing on with our cardiac congenital structural defects. Learning objectives is to explain the components of a cardiac exam, discuss pathophysiology of the pediatric patient with cardiac defects, discuss clinical manifestations of pediatric cardiac defects, discuss nursing management of patients with cardiac defects, recognize clinical signs and symptoms, and differentiate between the different structural defects of pediatric patients. So we're going to talk about right now what we call the VSD, which is, like I said earlier, the most common congenital heart defect. Talking about atrial septal defects, patent ductus arteriosus or PDAs, coarctation of the aortas, and transposition of the great arteries. So those are what we'll cover in our types of structural defects. Holes we would consider like connections between two sides of the heart are ASD, VSD, and PDAs. They can vary in size, which means that they can vary in severity and the symptoms that they cause. You can have a child with a very large VSD or a very small VSD. The child with a very large VSD is going to be more symptomatic than the child with a smaller VSD, of course. So these are also going to be cyanotic and acyanotic. They are generally acyanotic defects because the pressures in the heart have the oxygenated blood flowing from left to right, but if they're very large, pressures change, the pressures in the lungs change, pressures in the systems change, they can actually become cyanotic defects. But that's good to know that they can be cyanotic or acyanotic depending on their size. Repair and treatment will depend on the severity. Also, when this repair happens will depend on the severity. What kind of treatment that they have will depend on the severity of the defect. Signs and symptoms, you will hear a murmur. So anytime you have a hole or connection between two sections of the heart or the structures, you're going to hear a murmur because you're going to hear blood flowing in directions that it's not supposed to be flowing. So in general, when you hear a heart sound, you hear the S1 and S2 because those blood is supposed to be moving into the atriums and out of the ventricles, and all the blood should be going into those spaces. But when you have connections, you have blood moving back and forth during those times between systole and diastole. Another symptom you're going to see is fatigue. They're going to get very tired very easily. They're not going to have a lot of capacity for extended periods of activity. Sweating, they get diaphoretic. They have rapid breathing or shortness of breath. So if their heart is working hard, their lungs are also working hard because the cardiovascular system and respiratory system are very connected. So if one is working hard, then the other is working hard as well. Congestion, you might have pulmonary congestion or you might have edema. So this isn't like nasal congestion, we're talking about congested. Basically, the lungs become congested because there's extra fluid flowing to the lungs. Can cause a backup, so we can have edema in areas. We're going to have fluid overload, so we can have to watch for those things. They may have failure to thrive or small for their age because they tire very easily when they're eating. So we need to make sure that they get enough calories again to grow appropriately, to hopefully if they need to grow in order to have a surgery, or they need to have enough calories to maintain their body weight because the heart, if it's working harder, is using more calories and using up all the calories that they need. So they often have poor weight gain. This is exactly the reason for the edema, and because of their weight gain, it is very, very important to weigh these children every day when they're in the hospital to make sure that they're not either gaining appropriate weight, or they're not gaining too much weight, or they're not losing weight as well. So those are very important things to assess when they're in the hospital. So here's just some pictures of your VSD, ASD, and the PDA. So you see your VSD is between the two ventricles. Your ASD is between the two atriums, and the PDA is the aorta connection that it has with the heart. The PDA, the little hole that's connecting the aorta to the right atrium. So treatment, sometimes depending again on the severity and the type of defect, we could do a wait and watch. For PDAs, it could be a wait and watch. Hopefully, usually the PDA should close on its own. Sometimes it does not. And so we give it time to do it on its own. If it doesn't, then we intervene. We can have medications. Use medical closure for PDAs, surgical closures, and the treatment can include a cardiac cath. Like we discussed in the last video, is that cardiac catheterization can be used for treating a cardiac defect. So they can go in there and patch that hole between the heart if the defect is small enough. So this is kind of what I alluded to before. So this is the fetal circulation, and this is just to highlight that during fetal circulation, you have the PDA is open, the foramen ovale is open as well, and the ductus venosus is all open. After birth, because of the pressures, these all should close. So you should have your ductus arteriosus should close, your foramen ovale should close, and your ductus venosus should also close, and those things should happen after birth based on the different pressures. For PDA, a treatment includes indomethacin. It's giving non-steroidal anti-inflammatories, usually by IV. I believe they also use acetaminophen these days as a new treatment for it. So they first try and give, and this is IV, so this isn't giving the baby's PO, this is through IVs that they give these medications, and they hope that the PDAs close because of these medications. If they don't close, then they can go and do a surgical repair, and the surgical repair can include a clipping the PDA in the cath lab. So going in there, doing a catheterization, finding the PDA and clipping it. And then again, like I said, we have a wait and watch and see what happens if it closes. If it does not close on its own, what happens is that there is extra backup into the lungs, so there is more blood flow that goes into the lungs that can cause problems, can cause pulmonary congestion, can cause pulmonary hypertension. So we want to minimize that blood flow into the lungs, backflow into the lungs from an open PDA or a patent ductus arteriosus. So now we're going to talk about coarctation of the heart. So it is a narrowing of the aorta, the main artery that delivers oxygen. So there is, as you can see in this slide, as the aorta comes off the heart, it will narrow and cause an obstruction, and that prevents blood flowing into the systemic system. So you're going to see possibly a lower blood pressures. You can see lower oxygenations because of the coarctation going into the rest of the body. The heart also becomes fatigued because it has to pump harder to get through this stenosis and this obstruction. So as it's pumping harder, you might see a failure of the heart. So you'll see signs and symptoms of congestive heart failure if this is not fixed. So here's a couple of different types of coarctation. You have your preductal coarctation, basically meaning that the coarctation happens after the other branches off to the head and to the right side, or you have a postductal. So it happens a little bit farther down. So preductal versus postductal will also depend on the signs and symptoms that you see. So you might see with coarctation of the aorta, higher blood pressures because not lower, sorry, I think I said lower before, you'll see higher blood pressures in coarctation of the aorta because the systemic system has to work with the lower blood flow that's happening because of the coarctation. You will also see heart failure symptoms, which we talked about earlier, includes fatigue, diaphoresis, rapid breathing, pulmonary congestion, failure to thrive, poor feeding, and then you'll have femoral pulses. So this is when you check the femoral pulses and you'll feel a weaker pulse in that area if they have a coarctation of the aorta. Here is just a slide that you can look at of what they do for a surgical repair. So what they'll do is they'll open up the aorta here and put a patch on there, and hopefully it will stick and it will grow with the patient, and that will fix the problem.